Well, you shouldn't do that. You see, I lasted just a bit longer as a politician than that. That may make you think that if some of you become a minister, you might not want to open this agenda if you want to last. Thank you to all these organizations for having me here. Thank you. And to all of you, I mean, the 6 or 7 sessions I've attended have been fascinating, so it's fantastic work you're doing. And I certainly wish many more policymakers in Europe were just able to listen to you, so we'll try to disseminate your work from so far to Europe. I'm going to talk a bit about what's happening at the policy level. I'll be saying a bit of things, the things I've done in the Basque Country and other people are doing in Europe, because I think there's some really interesting common denominators happening across Europe. You've probably felt them during these days. We're all trying to do this journey. At the policy level, you just heard another example. You've been hearing others from Anne and others this morning. We're trying to get away from this reactive, acute biomedical model we're all in, going to more of a proactive, accountable care, population health, and trying to reach that big goal of health in all policies, broader intersectoral work that WHO has been promoting for now 500 years. The important thing is, of course, I present this as a sort of linear fashion. One can be doing intersectoral health for all work up front while you're still in a reactive, acute biomedical model. But I think the important thing is that where we're going with integrated care and population health is sort of preparing the scene for that broader intersectoral work. So I think it's very powerful where we are. In red, you can see what's happening, and I won't go into detail because you've heard some fantastic stuff on that these days, what's happening in terms of what's happening in finance. We just heard the example from Quebec, but you can see that everybody's trying to play less with paying for activity, going towards some sort of value-based payment scheme, passing through bundled payment, global payment schemes. And even some people are trying to now start financing, of course, community development in a more of an intersectoral way. So so it's a very interesting moment to be in. And obviously it's a very interesting moment for this group to continue with this agenda, which is probably the group which packages this together in the most successful way. In green, you can see the delivery level, millions of things happening at that level. A lot of the work that's been presented here in other conferences just is basically showing the other 2 levels the way. So it's the people working at that green delivery level, which is saying, you guys up there are not really pulling it off. We're doing something really cool here at the delivery level, and we're not getting sufficient support. So I just want to talk a bit about what should be and what is happening at the policy level, at the blue line, in some countries to start accompanying much more and much better the delivery level. And that's one of the things we study most in the University of Deusto, which is trying to get policymakers to create conditions, better conditions for that work at the other levels. Now, if one reviews what's happening mainly in Europe, but this is looking a bit at the States as well, we have, of course, very different systems, but we have the same policy intent. Everybody's trying to do that journey in one way or another. We're trying to get beyond fragmentation, targeting better chronic condition management, improve patient-centeredness, ensuring broader population perspective, better balance between illness and health cultures, and changing payment schemes to encourage value. All that is, each of those is a world in its own and difficult to achieve, and that's why we hear barriers and antibodies continuously in most of our systems. But I think what's really interesting is that we are beginning to pull it off. You are beginning to pull it off. So we have this same common problem. We're beginning to have the same common names. We have what's been called precision medicine. It's absolutely fantastic what's happening in medicine. I won't go into that. Nobody here is working against medicine. This isn't the health integration agenda is not even a clinical issue. I mean, that's just takes a life on its own, and it's doing some fantastic work. So that's not where the problem is. We are getting more and more what we call precision management, where we have frameworks and tools and all types of technologies which are going to help us in that direction. The patient is saying, and we've heard, provide me with more continuity of care, but in some places we're not listening. We're beginning to have, of course, some very positive results. So with all those preconditions, it looked like we should be able to, to move faster. And we keep on hearing, why are we going so slowly? And I think one of the reasons is because there's not enough policy influence, policy energy into that. So I won't go into precision medicine. These are all the things that are happening, of course, all the frameworks. These frameworks are extremely interesting because they're all system frameworks, whether it's the triple aim or whether it's the chronic disease framework or it's risk stratification. Whatever frameworks we use to go more into system thinking, it looks like we actually don't need new frameworks. We've all been leaning on some of these frameworks, and these frameworks now appear in different policy documents right across the world. So they seem to have hit a chord in most places where they are seen as useful to move in the direction we're saying. We have full of tools, and I won't go into the tools. Okay, so as we move into system management, we're trying to manage communities instead of managing structures, as we've heard. And if one looks across, and I didn't have enough information about Australia, but it's absolutely fantastic what you're doing in this part of Australia, at least that we've been hearing about, because here, obviously, there is that policy push. But in Netherlands, people are calling this shift towards this community system, care groups. In USA, accountable ACOs. Scotland, we've heard about them. England, etc. Northern Ireland, New Zealand, and in the Basque Country, microsystems. It doesn't matter what we're calling them. We're all calling the same. We're all calling using a different name, but I think we're all talking about the same thing, trying to get some sort of local, loose or tight, structural or not structural system going in our systems. And what's important about, I think, this slide is that it's happening. It wasn't happening 5 years ago. It's happening. And so the more we engage, the more we learn from each other, the more we connect, the faster we'll be able to go in all these things. There's some really positive results, which I think sends very positive. Then there's, let's say, one can be pretty optimistic about the benefits of continuing down this line. I think there's more and more information around improved outcomes in a lot of the work. Patient satisfaction improves when one pulls it off in the examples we've been hearing. Patient safety, increased use of care plans, new roles for staff. On the reducing cost, or let's say return on investment, it's a bit more ambiguous. There's some positive stuff in some places and not so positive stuff in other places. But the other outcomes seem to be a huge benefit just to pull off. And I think little by little, if we wait enough, we'll see the reducing cost type of work. The evidence of impact, this is from Scotland. You can see that there's evidence, there's more and more evidence. And I don't want to insist too much on this because we've been hearing about this is from a project in Bilbao in Spain using telemonitoring, and we've heard a lot about that. And this is the more traditional stuff of Kaiser Permanente. Now, I just want to talk, therefore, about the policy work that I think is beginning to happen, which we were doing for WHO in part. Now, is there sufficient pull and push? The policymaker is a small guy, okay? He thinks normally, you know, because of our egos, we think we're the big guy, but actually you're quite small. Some countries are actually beginning to create conditions at the policy level in a very successful way, and we've heard some of these. I just want to mention what the thinking is at the policy level and how they've been moving forward on this agenda. So most policymakers actually in many countries are basically saying, my present healthcare system is not a system, so I don't really know why I'm calling it that. Business as usual will not create the required organization of the future, so I have to do something else. Complex change therefore needs to take this issue up to the policy level. It can't stay just at the delivery level. I have to bring it up to politics. I have to turn this into a political agenda. It is not one more political agenda. It is the political agenda for transformation, and I need to bring it up, therefore, to that level and convince the political agenda, the people to engage in it. Most countries in Europe, at least, and I think elsewhere, have been trying to do, let's say, two big things at the same time, which is a resist culture, which is okay, you know, you're doing cost containment stuff as a politician just basically to survive. And actually, strangely enough, there's some politicians that stay there for 4 years. So they're just resisting. So they're doing things with staff, with drugs, or with whatever, but that has a huge problem. It doesn't change anything. You please your finance minister politically, but you're not changing the healthcare system we have towards what we need. So you need to go into a more transformative agenda, which is the one we're talking about. It's tougher, it's much tougher, but that's the one that changes the status quo. Now, in most of these countries that I'm talking about, senior leadership is quite disruptive. You use your political capital for this transformation. You shouldn't be using it just for cost containment, because that doesn't change too much. So if you're going to use your political capital, use it for something which adds value. So there are different statements from different countries which actually are very provocative, where you can see how disruptive. If you start saying in a country politically, in your parliament, the home is the hub, like some countries have said, I think this comes from Scotland, that's a big statement in healthcare, instead of saying the hospital's the hub. Or new payment mechanisms. I'm going to pay for value. I'm going to start paying for value instead of paying for activity. So that sort of sends strong signals into the system. So you can see from Christensen that only positive disruptive innovation is really going to have the potential to change some of this. So if a politician takes this on, it's very important for them to be able to have some sort of organized implementation plan and not be improvising right through. Now, what's that implementation plan look like when one asks? This is a sort of questionnaire I did over 4 or 5 Europeans and 3 or 4 Americans. Well, in most of them, the senior leadership in engaging in that transformative agenda was basically saying, we're doomed. So they spent time telling everybody, we're really doomed here, which is creating the need, which is creating, I think this is fairly important, because sometimes if you just jump into the solution, you haven't really created the need. So your health professionals, at least my health professionals in the Basque Country, well, they still don't get it, but they weren't getting it at all at the beginning, because they didn't know why we were launching this chronic care agenda. So it does provide this doomed agenda, provides information for a much broader consultation process. And people from Netherlands, the head of the health insurance system in Netherlands was basically saying, the "we are doomed" agenda, the creation of the need for doing something else, opened my discussions with the unions into a new type of conversation, which was more open than the one I was having. Senior leadership then presents a sort of policy proposal, a policy agenda, which as you know, in many organizations, the limbs are moving, but there isn't too much of a head. So there's no vision, and there's no cohesive strategy. So what's really interesting, I thought it was a consultant type of thing to put a vision. But actually, if you put a vision as a politician on the table, it's very interesting. It provides structure. It provides some sort of uniform agenda that people can hang their projects on. Otherwise, there's nothing. There's just somebody doing a whole bunch of cost containment stuff. And so if you, in addition to that, you put this vision on it, I think it's important because it provides the agenda. Now, coordinated and integrated care sort of provides that vision, but it should not be, as we just heard before from the Quebec, it should not be presented as a structural move. It has something to do with patients. It has to be about patients. So if one goes and says to one's parliament and says, I'm going to do integrated care and I'm going to do this really interesting structural move and integrate just about everything I can integrate, that doesn't turn anybody on. What engages people is, of course, a vision which has something to do with patients. Continuing these questions to these senior leaders is everybody was trying to find some sort of better balance between push and pull strategies. So everybody's trying to find how to play better bottom up. But actually some things have to be done top down. And I think it's important for politicians and people who are leading the system to know which they have to do top down and which they have to do bottom up. In Spain, we're really good at top down. Well, we've been doing it for 500 years, so that's one of the reasons. But basically, we're weak at bottom up. So it's almost anti-cultural to try to make things emerge from the bottom. But some level of orchestration has to happen from the top. And then at the same time as you're doing some of that orchestration, for example, on payment reforms, you don't want 15 payment reforms. You want one way of contracting for value. You can't have or you want one type of electronic medical record. You don't want 15. So that's top-down orchestration. But there's a moment you have to stop that and go into what's called traditionally more distributed leadership. What we did in the Basque Country and what others are doing is trying to find a new balance between that top-down and bottom-up. I'm not going to go into the detail, but just so that you see which are the top-down stuff and the stuff that you don't know how to do, and that you know that the people at the delivery level are going to do much better than you. You have to create conditions for that to happen bottom-up. And in some of our cultures, most people had not been given the leeway to invent their thing. And we said, well, look, you develop your little ecosystem. You start developing it. I'm going to create conditions with some of this top stuff, but I'm going to give you leeway to do. Yeah. So you don't sleep as well as with the illusion that you're actually micromanaging everything. You actually launching a much more chaotic level of organization, but actually the result is very, very interesting in many of these settings because you get a lot of new types of innovation coming from people at the delivery level doing their thing. So in order to do that, you have to get into something some people call a high involvement culture with healthcare professionals. It can't be done without healthcare professionals. If we could actually go into integrated care and all these things without healthcare professionals, I can tell you we would have done it. But actually, you have to engage healthcare professionals in a much more participatory process in order to give continuity. Now, what's really interesting in my case, in the Basque Country, is that when I was sent home, the next guy around, because we had launched in a very emergent way 150, 200 bottom-up processes, he could not stop it. So you have something which is no longer dependent on the politician that was that. So in a certain way, if you work a lot bottom-up, you actually can begin to jump some things in the political cycle, which is really important, maybe not in all countries, but in our country, it certainly is. So you go into these high involvement cultures, which requires local providers to innovate organizationally. This is Weston Dawson's work, which I think is fascinating in terms of why do you need to involve professionals? This is on 13 or 14 hospitals in the UK, but it's being repeated in different places. But the more you engage staff, the better the quality is, the better the patient satisfaction is, the better the mortality rate is in that hospital. And what's really fascinating, the better the money, the economics of that hospital is working. So involve them. Senior leadership sought early wins, and this is what very interesting in those interviews I conducted. Don't let the early wins be your early wins, because you want to be able to show off the results as the minister at that moment. But actually, if you actually truly believe in emergence and letting the bottom-up work, let them not be your early wins. It's their early wins, and not blah blah. You actually make noise about what people are pulling off in their different experiences locally, and therefore that creates sustainability. That creates a whole bunch of things. So early wins. We've all heard about early wins. It's one way moving forward again. But I think what's interesting is make them local. Make them local. Now, therefore, allow models which permit local organizations to retain some of the efficiencies found. Across the different models, we had the one we're doing in the Basque Country, the ACOs, different models are trying to say, if you want them to continue in time, make sure they can retain some of the efficiencies that they're pulling off when they're doing it. This is just the Scottish route map that Derek did at the previous conference last time. This is what we did in the Basque Country. This is what the IHI, the Institute of Health Improvement, basically indicates as a framework for implementation. I'm just signaling them because there's more and more frameworks for implementation, because that's where our difficulties lie. We don't have a problem about what to do. You've probably noticed one presentation after another. We know what to do. There's growing evidence about what to do. But how to do it is what we need. So we need to think about how to do it. So just to finish off, make it policy if you can make it policy, if you're in a position to make it policy. Move many levers. One lever is not going to pull it off. Just a bit of patient engagement, empowerment, or just the electronic medical records are not going to pull it off. Just the technology is not going to pull it off. We talked before in another session about technologies, and well, we have extremely mature technologies and very immature organizations. So we have to make sure the organizations become more mature so that they can embed those technologies. Efficiency drive, make sure they're shared savings arrangements. Pilot, yes, of course, but generalize as much as possible. And then I would just insist, just to remember, just let self-discovery from an emergent way go. And definitely at the policy level, when one of you or some of you are named ministers, just don't make little plans, just make big plans. This is something that town planners just said at the beginning of last century, 100 years ago, but the little plans have no magic to stir men's blood, and probably in themselves will not be realized because they're too little. So make them big. Thank you.